Hello, welcome to UPMC Sports Surgery Clinic talk on spinal injuries and spinal conditions. I'm Fiona Roach, I'm the General Manager here at the Sports Surgery Clinic. Any of you that don't know us, we are in Santry in Dublin. We're about 10 minutes from the airport, just off the M50 and the M1. We look after everything here, musculoskeletal, your joint replacement surgery, hip and knee, shoulder, spinal surgery, hands, shoulders, foot and ankle as well. So tonight we've got two speakers. We've got Mr. Sam Lynch. Sam is one of our orthopaedic spinal surgeons here. And we've got Claire Whelan, and Claire is one of our spinal physio leads here as well. So both of them will have their presentations. They'll both join us after their presentations for a live question and answers. So you can see the tab there to ask a question. Please type in a question for them, and we will endeavour to get through all of them tonight. If not, we try and answer you afterwards by email. Now, there are other tabs there as well, you can see. So there's ones about events that we've done in the past. They're on things like golf, walking, hiking, skiing injuries, hip and knee replacement. So if you want to go into the website, you'll find them there. This one will be recorded as well and will be up on the website in the next week. So if you know anybody else and you want to direct them there, please do. We will send out a survey afterwards to see if you have any suggestions for future talks and how you found the talk. Now, UPMC, our hospital is part of a group. So the group also we have other hospitals in Waterford, which is the Whitfield, Orthaven, which is in Kilkenny, and Clane in Kildare. And we do have sports medicine centres scattered around the country, and they're all on that tab there you see about UPMC. So I hope you enjoy tonight. Please type in your questions, and we're going to start with the first presentation now with Mr. Sam Lynch. Thank you.
Good evening, everyone. Thanks for coming to the seminar. My name is Sam Lynch. I'm a consultant spine surgeon working in the Sports Surgery Clinic in Santry, and I've got public appointments at the Mater Hospital in Dublin and the National Orthopaedic Hospital in Kappa. So I'm going to speak to you about innovations in back surgery, but the first thing I'm going to do is address some of the myths that surround back surgery, right? And the reason we're going to talk about this is because if you don't understand the right way to treat it and the causes behind it, it's very difficult to get to the bottom of it, right? And I think everybody accepts that it's a complex issue, right? And it involves more than just surgery or more than just physiotherapy. Everybody has to be involved. But there's an awful lot of disinformation out there surrounding back pain, both in the causes of it and the treatment of it. And I'm going to hope to address some of these for you tonight. So the first myth, of which there are 7, is that if you have a slipped disc, you must have surgery, right? It sounds like I'm trying to talk myself out of a job here now, but I'm not. 50% of people with a slipped disc, regardless of the size of it, provided that they don't have any weakness in their legs or any alterations in their bowel or their bladder, so if they can go to the toilet normally because after the disc prolapse, they improve without surgery, right? And that improvement happens within 12 weeks to 6 months. Of the 50% that don't improve, provided that they've had the proper treatment, which would be physiotherapy, movement, non-steroidal anti-inflammatories, and in very specific cases, injections. If they don't improve within 3 to 6 months, it's reasonable to consider surgery. The reason we consider surgery to take the pressure off the nerves, the disc is like, what I like to describe it as in the clinic, is like a cod liver oil tablet. It has a hard shell and a soft center, right? When the disc bursts, the hard shell around it splits and the contents of the disc spill out into the canal. You can see it up here in the diagram on the right. You can see that blue part of the diagram is pressing on the yellow bit, which is the nerves. So you can see that that's what causes your pain. Most of the time, and 50% of the time, your body will resorb that disc. It'll just dissolve it away over time. If that doesn't happen, it's reasonable to consider surgery for it because you can develop a chronic pain syndrome, which is very debilitating. So the first myth around surgery is that if you have a slip disc, you must have surgery. That's not true. You may need surgery, but there are other things we can do first. The second myth that we often encounter is that when you have back pain, an MRI scan or an X-ray is going to give you a cause for that pain. In the main, that's not true. In the main, and this is my worst nightmare, and any medic's worst nightmare in the clinic, is you've got someone with real and debilitating back pain and absolutely normal scans. That doesn't mean that they don't have pain or that their pain is in their head or it's not a real, it's a real entity. It's a very real entity. It just means that from a spine surgery point of view, there isn't a surgical target for their pain. And oftentimes the patient's history, what they tell us when their pain comes on, what makes it worse, what makes it better, and how they examine. So when we examine people and ask them to move, to bend, to examine the power and tone in their legs, that will often give us more information than imaging. So just because you have a normal MRI scan and a normal X-ray doesn't mean that you don't have a real problem. It just means that it's a more difficult problem to fix. The third myth, and this is one we hear all the time, and it's one that your mother would have told you back in the day, is if your back hurts, you should rest until the pain goes away. That's the worst thing you can do, right? When you've got an acute flare-up of back pain, you need to take some painkillers to try and get you over that pain, and then you need to start moving gradually as quickly as you can. The more movement you can tolerate, the better, and the quicker you get back moving, the more likely you are to recover. And this is especially true in an elderly population, because the older you are, the less likely you are to regain movement once you've stopped moving. And that's the same for anything. It's the same for back pain. It's the same for hip pain. It's the same for knee pain. Once people stop moving as they get older, it's very difficult for them to start moving again. So the takeaway from this is that back pain is helped by movement after the initial day or so of acute pain. The fourth one we have is that most back pain is caused by injury or heavy lifting. Right? That's also not true. Right? Back pain is so common that we're starting to consider it as normal. Right? If you don't have back pain in the course of your life, you are in the minority, not the majority. And this lady on the right, she's an Olympic champion weightlifter, right? And I'm quite certain that she doesn't suffer from debilitating back pain. So the fitter you are, the healthier you are, the more active you are, the less likely you are to have back pain. If you obviously go into the gym and lift weights with bad technique, you'll injure yourself, but it's not a direct relationship between activity and lifting and back pain. The fifth myth around back pain is that it's usually disabling. We often see people in the clinic and they're coming to you and they've been in pain for an awfully long time. And pain is an absolute leveler for everybody. If you're suffering from chronic pain for a long period of time, it wears you down, right? And people get to a point of desperation where they feel that there's nothing that can be done to help them, right? Whereas the reality is that if you have a more holistic approach to the management of your back pain, treat it like it's a chronic condition, using a kind of a multidisciplinary team approach. So you involve spine surgeons, you involve sports medicine physicians, you involve physiotherapists, you involve psychologists. All of these people combined can help you overcome your back pain. There is no one person that can do it, right? But if you're given the right tools by multiple people, back pain can be conquered, but it's very difficult. But it certainly isn't a life sentence, which is often what people feel by the time they get to see me. The sixth myth is that everyone with back pain should have an MRI scan or an X-ray. Right? And the reality of it is that there's only very specific reasons to get an MRI scan, and that is back pain that causes leg pain or leg numbness or heaviness in the legs or weakness. There's normally no real need for imaging of any kind, x-rays or MRI scans, unless you have some of those symptoms, or unless you've tried other treatments like your physical therapy, your physiotherapy, your pain regimes, and your lifestyle modifications, and you're still having ongoing pain, then it's reasonable to start thinking about an MRI scan. But because they're so easy to get now and they're not too expensive anymore, we're very liberal in their use. And oftentimes I think they confuse people because they don't highlight anything that we can target. And the seventh myth, and it's the worst one, is that bed rest is the best therapy for back pain. It really, really, really is the worst thing you can tell someone to do when they start getting back pain, is to lie in bed for days at a time, because your back needs to be in a curved position. It assumes that position when you're standing upright. When you're lying flat, your back gets straight, which straightens the muscles even further, right? It alters your posture into one that generates pain. So it actually makes your acute pain worse. So people with acute back pain should stand as best they can and start gradually moving, right? A period of bed rest never helps anybody, and it's associated with increased and prolonged duration of your back pain, an increased risk of blood clots, depression, right? And it just doesn't help, right? So bed rest is not the best therapy for back pain. It's one of the worst things you could possibly do. Although some people do say that it's the only thing they could do. So I do understand that in the real world, sometimes people have to take the bed for an hour or two, but spending days in bed is not what you need to do when you have a bad back. Well, and we've seen it now, the epidemic of back pain. It's more prevalent in the States, but there's a huge issue now with opiate addiction, with as a consequence of indiscriminate prescribing of opiate medications in the treatment of back pain. Because, and oftentimes, not to vilify people, but oftentimes that's just because it was all that was available to people to manage their pain, right? But we know that it's more than just opiate medications, morphine-based medications. That's not what people need. People need a multidisciplinary team approach to their pain to help them manage every facet of their life, because everything about your life impacts on your ability to cope with back pain, right? You can see that, and these are American numbers as well. We don't have the numbers in Ireland, right? But there's like MRI scans. They're over ordered by 300%. That means that like 1 in 4 MRI scans give us information that we can actually use, right? In the opioid prescriptions, I think they're much less regulated where this data is coming from. But opiate medications are dirty medications. They're really good for pain, but they're really bad for everything else. They cause addiction, drowsiness. They cause problems with your digestion. They cause constitutional problems. They alter people's mood. So they're really, really really should be avoided, and they're in a medication of last resort that should only be prescribed for short periods of time. Spinal injections, these are really, really powerful when used properly. They're really, really effective, and I do them in very specific instances in my clinic, and I know some of my pain colleagues also use them to great effect. But you have to be very discerning about their use. There has to be a surgical target that you can see on the MRI scan, and that is directly linked to the patient's symptoms. So it's very important that you take a good history, that you do a good physical examination, that you look at the x-rays, and that everything matches up together before you start injecting. Because while they're very low risk, there's still risks associated with them. And there's no point in doing any intervention on someone unless it works, right? And then spinal fusions, again, in America, because the financial, their health services is very financially driven, and so fusion procedures pay more over there, so they do them an awful lot more. And it's almost a purely private system, so their degree of fusions is much higher than it would be in Europe. So what we've established here in the Sports Surgery Clinic in Santry is what we call an MDT, a multidisciplinary team, right? And the reason we do that is that it is a complex problem, albeit a very common problem. It's still a complex problem, and each individual's the source of each individual's back pain is different. The causes that are driving it are different. The modalities that we use to treat it will be different. And unless we give people long-term tools to cope with their back pain, as well as the therapeutic interventions that will help get rid of it, people aren't going to get better. So the MDT that we've set up here in the Sports Surgery Clinic in Santry consists of spinal surgeons, of which I'm one. I'm really the last resort in the treatment of back pain. And the skill set that I bring to it are only applicable to a small minority of patients. Most of the patients will be dealt with by the other members of the team. These include the pain physicians, who have great expertise in targeted injections, non-opioid pain medications, other pain strategies. Then we've got the physiotherapists, who are the mainstay of the treatment for most people with back pain. They tailor the exercise-based rehabilitation programs to the patient's needs and the pain generators that the patient has. Psychology is very important in the management of back pain, because especially if it's been going on for a long time, it can come to dominate your thoughts, and people often come to us in a desperate state because their pain has been ongoing for an awfully long time and they feel disempowered by it. It just controls their life. They don't have any control over it. So CBT, or cognitive behavioral therapy, is a very powerful tool for people to learn to manage their pain. It gives people back power and control over their own lives, and it's one of the fundamental tenets of what we're trying to achieve. And then the sports medicine physicians are very good for devising return to lifestyle programs for people. They get people back to where they want to be, back to where they started from, be that playing sport, going for a walk, just living a normal pain-free life. So you can kind of see that the management of back pain is really complex. It takes more than just a spine surgeon to do it. And really, a spine surgeon, while they have an important role at the thin end of the wedge, they're not central to it. They're part of a team. So the MDT will begin with a comprehensive physical and psychological evaluation of each patient. We look at the physical shape that they're in, how their exercise tolerance, their cardiovascular fitness, but you'll also look at the psychological stressors that they're facing in their lives. We know that people who are going through any kind of psychological stress, be it a bereavement, marital problems, general life stresses, job changes, moving house, anything that diminishes people's capacity to cope with any kind of pain. And it also increases the likelihood that they will develop back pain. So all of this is important, and it needs to be factored into their treatment algorithms. And then based on this, you get a treatment plan that involves either the spine surgeons, if there's a mechanical cause to their back pain, or the physiotherapists, the psychologists, the nutritionists, and the sports physicians. Pain management is really important, but we really need to not use opiate medications if we can, because while they're very good for pain, as we said earlier, they're very bad for everything else, right? And over time, then we try to give people back the power to get rid of their back pain, right? But it takes time, It takes buy-in from everybody involved, both the patients, the GPs who are referring them to us, and the members of the multidisciplinary team. Right, and once we get people back up and moving, that's what we consider a success. So it sounds like I've spent the last 20 minutes talking myself out of a job, right? But like most of the spine surgeons across the city are very, very busy, and for good reason, right? Because even though most cases of back pain don't require surgery, surgery is a very powerful tool, and it's essential in some instances. And they're very specific instances. So the first one is if there's nerve compression. So the nerves come off the spinal cord at the base of the spine and go down into your arms, go down into your legs, supply the power, the sensation, and the movement to those limbs. If they're being compressed by anything, be that a slipped disc, an infection, a tumor, any kind of injury, then spine surgery is essential to take that compressing element off the nerve before it completely obliterates it permanently, right? The second indication for spine surgery is if when there's any structural spinal instability, right? And this sounds very fancy, right? But there's a couple of instances where this is relevant. The first is scoliosis. This is a progressive condition that gets worse when people are growing quickly, which is why we see it in young adolescents during their growth spurt. We know that curves, we measure the absolute size of the curves, and curves over 50 degrees, when we measure it on the x-ray, they tend to progress into adulthood. Curves under 40 degrees, they tend to stop when you stop growing, and curves between 40 and 50 can go either way. So we know that over time, large curves in scoliosis get worse, and it's better to fuse them, to fix them. The third indication for surgery would be serious conditions like fractures, infections, or tumors. We deal with a lot of these in the Mater Spinal Injuries Unit, which is one of my public appointments. And it's not really relevant in an elective setting, because these conditions, they tend to require surgery immediately. So we'll often see these, and we'll operate them on the same day or the next day, depending on when they're referred to us. So spine surgery is important, and it has a huge role, but people have to be discerning about when they use it. I'm just going to briefly touch on each of the indications we've discussed, right? So surgery for severe nerve compression comes with severe leg pain, what most people would know as sciatica, right, which isn't improving. So if you've got a herniated disc, it's pressing on your nerve. It's causing you severe, unremitting leg pain that hasn't gotten better in the first 12 to 24 weeks, despite your best efforts at physiotherapy and pain medications. Then it's probably reasonable to see a spine surgeon to get that disc removed before you develop a chronic pain syndrome. The surgeries that we would do would be a microdiscectomy, which is where we make a small window into the spinal canal to remove that bit of herniated disc, that bit of disc protrusion that's pressing on the nerves. In very big discs, or discs that are in the center of the spinal cord, we'll do a slightly bigger procedure called a laminectomy, where we take the bony arch off the back of the spine to relieve the pressure. Right. We tend to do that for what people will know as cauda equina syndrome. And that's when the disc is so big that it compresses the nerves that control your bowel and your bladder function. That's a surgical emergency, and we would do that overnight. If I was referred a patient during the day, I would do that operation the minute that patient arrived in my hospital. It's very rare, and it's on the same spectrum as a herniated disc, but it's at the extreme end of it. But in those scenarios, you do the larger laminectomy. And then the surgery for structural instability and trauma, so that would be severe scoliosis, as we've discussed. Spondylolisthesis is a big word for one vertebra slipping on top of the other, right? So there's just a little bit of a step there, and that can sometimes cause pain, especially when people are standing. So that can sometimes need surgery. And again, fractures for trauma, which is, most often times you fracture your spine if it's a road traffic accident, or in elderly people with osteoporosis or soft bones, they commonly get spinal fractures from minor falls. The common fusion surgeries that we would do would be spinal fusions, which removes all movement between the bones in the back using rods and screws, or artificial disc replacements. The artificial disc replacements are again very powerful, but they're only relevant in a very specific population. You wouldn't do it in everybody. You certainly wouldn't do it in people who have got arthritis in the small joints of their back or arthritis in the small joints of their neck. You tend to do it for younger people who have relatively healthy backs in every other way except for at that specific disc. And we've lots of very fancy high-tech tools to make this safer. We have robotic surgery, which combines your CT scan with your on-table x-rays during theater to allow us to navigate the screws and the rods into exactly where we want them. So this is really powerful in that it minimizes the risk of any injuries to the nerves or to the spinal cord, and allows us to do much more complex surgery much quicker and with much less risk to the spinal cord. And then the other options we have now are endoscopic surgery. This would be for the microdiscectomy, the shaving the disc off in those herniated discs, and that allows us to do it nearly keyhole. And this is a new technology that's come on stream in the last 10 years that has really revolutionized how we can treat these common spinal conditions. So the conclusions of the talk are that most back pain is not serious and it will go away. The key to getting better is to move as much as you can. While surgery is indicated, it is the last resort in most cases. If you are having surgery, it's much safer now than it was in the past because we have an awful lot more technology at our disposal to make sure that the implants that we put in go exactly where we want them. But really, the more you move, the better you'll be when it comes to back pain. Thank you very much.
Sam, thanks for a really interesting talk, and we've loads of questions coming in already. So first one's from Cleaner. She's saying, how do people get referred into the multidisciplinary unit, and what's the process from the first appointment to determine who and what department they see?
So the GP will just write into the spine service here at the clinic, and then we'll just triage the referrals appropriately. So, we've got a lot of specialties available to us. We've got surgery, we've got the pain specialist, physiotherapy, sports medicine. So between us, we kind of appropriately delegate the patients to depending on the triage letter that the GP sends in, and it's very quick to be seen then after that.
Great. And there is another question there I'll ask you because it kind of ties in with that. Someone was asking, now they mentioned a neurosurgeon, you're an orthopaedic surgeon, but what's the initial time from appointment to surgery?
It's not long is the answer. A lot of it will depend on the complexity of your surgery. So if it's a simple, let's say the simplest thing I would do from an operative point of view would be a lumbar decompression. And the most complex would be a fusion procedure with disc replacements, etc. So a lot of it will depend on the complexity of what you have done. But if you have a simple procedure, you're talking within 4 to 6 weeks from consultation. Once we've gone through all the relevant planning and stuff, it's not an onerous waiting list.
Can you comment on the use of anti-inflammatories, duration, safe amount, and how long should I stay on them?
They're powerful medications in people who are fit and healthy. If you've got any problems with your kidneys, if you've got any problems with your stomach, any ulcers, they do have issues, and taken safely, like within the recommended doses, they're fine. If you're taking them for longer than a week, I would always put somebody on a stomach protector just for that. I would try to avoid them for longer than 2 weeks, mainly because you get increased risk of ulcers and they can cause kidney injuries. They are a useful tool. They're not addictive, but they have side effects, so you just have to manage them appropriately.
Does EMG have a part to play with diagnosis of radiating back, leg and pain? And is it more thorough for radiculopathy?
I would only use EMG if I couldn't figure out where the radicular pain was coming from. So radiculopathy in the main is relatively straightforward to diagnose if it's coming from your back. So the role of EMG is to find out if, let's say you have a normal MRI scan, but you have symptoms of nerve compression in your legs. Normally that's coming from your lower back, but if it's not in your lower back, the nerve can be compressed elsewhere after it's left the spine. So that's where I would get the EMGs, but I wouldn't routinely use them unless there was some ambiguity about the source of the problem.
Okay, thank you. Patient here they've had sciatica issues over the last year. Thankfully, the pain is gone. A doctor has advised that there was slight bulging on one of the discs and probably pressing on a nerve. Her question is, how long does it normally take for that bulging disc to go away? Or does it ever go away?
It does go away, actually. And I didn't put it in this presentation. I made a presentation recently. Like, it can be startling, the change. You can have an MRI scan taken, let's say, a year ago, and then a repeat interval at a year, and it's in some people it can be almost completely normal. So the body does resorb them, right? Like I mentioned it in the talk. Discs, they kind of go one of three ways in the first 6 months. So the pain either goes away, it gets better, or it gets worse. If it goes away, you don't need to do anything. If it stays the same or gets worse after you've done everything right and you have some kind of a compressive component to it, if there's a disc pressing on a nerve or if there's some other thing pressing on the nerve, it's probably reasonable to consider surgery at that stage.
Okay.
So, but in the main, your symptoms are kind of in the first 24 to 36 weeks will dictate how it's going to be long term.
Any experience of treating HSD? A lot of pain meds don't work for him.
Yeah, it's so that's like Ehlers-Danlos type conditions. It's very complex because, and while there's loads understood about the connective tissue conditions, it's still there's a lot of evolving knowledge there. So like, and oftentimes the pain generators are hard to identify. So, and as well as that person rightly points out, a lot of pain medications don't work. So that's definitely one that requires an awful lot of input from more than one specialty. I don't have an awful lot of experience like I have in terms of, I'm a scoliosis surgeon as well. So I have a lot of experience with people with connective tissue problems because they develop scoliosis as well. But in terms of management of pain, no, it's very complex, and you need input from some fairly specialist people for it.
Thanks, Sam. Another question here: can pain go away with lumbar stenosis L3 or 4? Active pain for a year, no back pain. Pain is more in the glutes, hamstrings, and the feet. No issues though with yoga or Pilates or strength training. But running is painful and can be painful. Walking usually goes away first thing. Any advice?
Yeah, general advice is do exactly what you're doing, right? Yeah. Which is all the right things, right? And it's very difficult to it's very difficult to piece together exactly what's going on there without seeing that person and their scan, because if you have leg pain without a significant component of back pain, that sounds very much like those nerves are being compressed, which is why it's worse when you're standing up, for example. So there are surgical solutions to it. Injections in that instance do work. As a general rule of thumb, if you have narrowing at the base of your spine that's due to just age-related wear and tear, it's unlikely to get better over time. It's likely to get worse. So it's probably worth seeing somebody about that.
Another few questions here. Someone now looks like what's your thoughts on nerve blocks for pain reduction, in the fact that he's already had 2 microdiscectomies, he's in his 30s, and he still has a herniated disc with a protrusion, but he's worried about having nerve blocks, that it will block the pain. I suppose that will he do any damage?
Yeah, and that's a really good question. That's a really good question, and it's one we have to deal with all the time. So there's 2 components to transforaminal nerve root blocks. There's two ingredients in the injection. There's the local anesthetic, which it's just pain relief in the first 24 to 48 hours. And then there's a steroid. What the steroid does is it takes down any inflammation around the nerves. Because when I do a discectomy, I've just done one in the last hour or so, when you take the pressure off that nerve that's been caused by the disc that's pressing on it, you see that the nerve is very hot and red and inflamed. It looks swollen and irritated. So the steroid takes down that irritation, and that gives it a lasting benefit. So injections, they're not about masking the pain. They have a therapeutic benefit as well. And again, it's nearly like a rule of thirds. With injections, about 20% of people will get no response, which means that you have to look for another source of their pain. If they get no response at all, even if they don't even get an hour's response from the injection, either the injection wasn't put in the right place or it's not the cause of their pain. The second group get a response, but it's transient, which means that you have to revisit possibly doing a surgery on them. And then the third group get a lasting response, which means that they either avoid surgery or you can repeat the injection at an interval. So it's more than just masking pain. It does have an anti-inflammatory effect that can be quite sustained.
Okay. Some of them got severe debilitating lower back muscle spasms and severe end plate disc degeneration. How would that be best treated?
Again, I'd have to, back pain in the absence of any leg pain is best treated non-operatively, right? If you have back pain and leg pain that are equal in measure, there are subtleties to it. These are all generalities, but if you've got back pain and leg pain, you can consider surgical intervention in the form of a fusion, right? And if you've just got leg pain that's bigger than your back pain, tends to just need a decompression.
Okay. We'll just get another couple in, and then I think
Not right.
We probably haven't got to them all. They can in. What happens if corner equina is left untreated?
It's a surgical emergency. So if it's left untreated, I work in the Mater Spinal Injuries Unit in Mater University Hospital as well, and so we would treat corner equina within hours of getting the referral to avoid long-term consequences with their bowel and bladder function is the main problem, right? You can also have weakness in your legs, but the long-term consequences of untreated corner equina are sexual dysfunction, bowel and bladder problems. So it's a pretty devastating condition if it's left untreated.
Someone's asking actually, what's the difference between an orthopaedic surgeon and a neurosurgeon?
So it depends who you ask now, and there's a couple of ways to answer that question. I'll try to be diplomatic about it, but yeah. So the common ground between orthopods and neurosurgeons is the spine, right? Neurosurgeons do brain surgery and they go from the brain and they can go down into the spine. Orthopedic surgeons do surgery on everything else, so every other musculoskeletal part of the body, and we do spine. What we're finding though is that if for both neurosurgeons and orthopedic surgeons, spine is nearly a separate specialty now. So there's an awful lot. I have an awful lot more in common with a neurosurgeon who does spine than I'd have with an orthopedic surgeon who does foot and ankle. We very similar practices. So in real terms, there's probably no real difference depending on the level of training.
It's like your spinal surgeons, really.
Yeah, we're essentially spine surgeons.
Yeah, exactly.
Right. There's differences within those. Like a brain surgeon is different to a spine surgeon in the neurosurgical side, and like let's say a hip and knee surgeon is different to a spine surgeon on the orthopedics.
Yeah, lovely, thank you. And just one last question then. Is playing golf possible if you had a T6 to T10 fixation?
Oh yeah, definitely. Yeah. Depends who fixed it now, right? But I'm sure if they've done a good job, yeah. The whole point, the T6 to T10 is most of the mobility in your spine comes from your lumbar spine. So, like, yes, is the short answer to that. You should do, provided it's you've healed up and everything is good. You should be fine.
Thanks very much. We couldn't even get through all the questions, but thanks very much for joining us tonight. And there is a tab there if you want to find any more information or you want to make an appointment, please do. Now, the next speaker tonight is our lead spinal physio, Claire Whelan, and Claire's going to join us live after her presentation. Thank you.
Good evening, and welcome to my presentation on the management of low back pain. So let's just start off with some statistics around low back pain. Low back pain is the leading cause of disability worldwide and rising. And it's estimated that over 80% of people will experience an episode of back pain at some point in their lifetime. And in 2020, a staggering 690 million people suffered from low back pain. So if you have low back pain tonight, you're definitely not alone. And tonight, as part of my talk, I'd like to bring you through some historical low back pain treatments, what an evidence-based care looks like, and tips on how to manage a flare-up of your back pain. So historical treatments, low back pain is nothing new, and it's been documented that potions and spells have been used by ancient civilizations. And Hippocrates, the father of medicine, a Greek philosopher and physician, even documented exercise and manipulation. So I hear you ask the question, what has changed? And in truth, not much. There's multiple non-surgical treatments out there, and these kind of range from core strengthening exercises, dry needling, manipulation, wearing back braces, taking even painkillers and having a spinal injection. The list is endless. And we can't forget our conflicting advice between colleagues and friends and our good old Google. But in essence, a lot of these treatments are actually quite costly, and when used in isolation, often ineffective. And a really good example I have is I had a young patient come into me last week, and she's been having weekly treatments for the last few months. And her back pain is still there. It's actually getting worse. And she comes in and she tells me that everyone's quite puzzled as into why she still has back pain. So she went on to have an MRI scan. And this is where a picture isn't 1,000 words. So her MRI scan came back completely normal. And we know from the evidence that having some age-related changes in an MRI scan is quite normal. And these changes increase with age. And I typically describe them as, it's like having wrinkles and grey hairs, and it doesn't necessarily correlate to a person's back pain. And another issue with, I suppose, an MRI scan, it's a static picture. It doesn't tell me how you move. It doesn't tell me, about muscle imbalances between your core muscles and your leg muscles. But more importantly, it doesn't tell me about your thoughts and your feelings. So this particular patient came in to me, and because she wasn't getting better, she really felt that something seriously was wrong. She was scared to move her back, and she really felt that she was going to do more damage if she was going to move into her pain. So she was protecting her back, having really good posture and not lifting anything heavy. And I'm going to talk about, these thoughts a tiny bit later on, in my presentation. So if we move on to current day, what does evidence-based care look like? So there's guidelines out there to help guide physicians as into how to manage back pain. And these guidelines recommend that we kind of have a combined care tailored to each person's needs. And this may consist of education around kind of like your back and your do's and your don'ts, exercise prescription, manual therapy, and for some people, psychological therapy. And again, for us as physicians, we want to give you some tools to help manage your back pain. So when we go on, what does recovery look like? So when we adopt kind of an evidence-based care approach, what does recovery look like? Well, most people would love to see the graph on the left-hand side. In essence, back pain, the recovery can be quite complex. And I always describe in the beginning, it's like a squiggle. And this is where, for us as clinicians, having a deep understanding about what's going on is really important. So we want to take a kind of an in-depth history about what's going on in your life, but also about some, fears that you have around your back pain. So many people are quite fearful of moving their back and causing recurrent pain. And I want to know about your expectations. Do you think it's going to get better? Because it's really important that for all of you out there that suffer from back pain, that you have this hope and hope that it will get better. But as I said, kind of listening to your story is so important because it helps us to tailor that exercise program to your needs. And once we kind of get on track, recovery is still going to have its peaks and troughs. And a kind of a good example of where I really want to figure out what's going on in your life is I had a patient a few weeks ago who came into me, and he had 3 weeks of really stable kind of low back pain. And he'd seen 3 other physicians prior to coming to see myself. And, throughout the assessment, we were able to change his pain through exercise. And I was like, well, this is great. Brought him back a week later, and he was kind of over 70% better. And I was really curious about, why, what got you better? And he actually said to me that it was a phone call with his boss. And his boss had given him some reassurance, going, look, don't worry about work, come back whenever you're better, I'll pay you for while you're off. And he came back and he told me it was that kind of reassurance that helped him to kind of, not panic about getting better. And in essence, it was, that social stress that was removed from him that allowed him to progress with his rehab. So after kind of getting like that history from you, what do I want to see? I want to know, are you breathing? How do you bend? How are you standing up from a chair? And what is your posture like? And for me, these 4 key, questions are really important, because unless we get the basics right, it's very hard to make improvements within an exercise program. So let's talk about breath. So many patients come into me and I'm like going, are you breathing? And they're like, oh, no. And I was like going, are you protecting your back? And they're going, yeah. They're all protecting their back because they're so fearful of causing, damage. And it's really important to know that your back is strong. 90%, over 90% of people with back pain, there's no one specific cause for it. And you hear the word kind of saying that most people say it's non-specific or it's benign in nature. But, it's not serious and it's not harmful, while it's really impacting your life and, causing you distress. It's not harmful. And when people come into me and I see that they're bracing and they're protecting, I kind of go to kind of a clenched fist, and I use this analogy, and I get my patients to make a clenched fist. And if you can all make a clenched fist now for me, and really, really squeeze your fist as hard as you can. Okay, and now I want you to try to move that fist up and down. And it doesn't feel that nice. And I hear a bit of clicking and cracking, and actually my knuckles are beginning to get a bit sore. And your knuckles in your wrist are actually the same as the joints in your back. So if you're bracing and holding your breath, you're probably increasing the amount of stress and strain going through those joints. And also, if I'm holding my fist all day long, I'm beginning to feel my forearm muscles get a bit sore. And I'm sure you are too there. And now I want you to move it. And now I want you to relax your fingers and just move your wrist up and down. It feels so much nicer. And that's the same with your back. So you need to breathe, you need to relax. And that's really, really key. And this won't probably come natural to you. So it's important that you're telling yourself, okay, breathe, relax. Feel your tummy. Does it feel soft? And the next thing I want to look at is, how do you bend? So your spine is made up of segments stacked upon each other. And within each kind of bony segment, you have a disc. And it's designed to twist and to turn. So by you keeping your back very straight, you're not allowing your back to do its function. And hence it kind of may feel a bit stiff and a bit tight. And these are some videos that I'm just going to show you of how some people typically move when they come in to see me. So the first video is someone kind of hinging forward. You can see here he's keeping his back really straight and he's just hinging from his hips. Another movement pattern that I typically see is that you bend from your legs and your knees and you're trying to keep that back really straight. But what I want to see when you come in to see me is that we're flexing, we're bending through your upper back, your mid back, your lower back and your hips. And this movement is quite nice. And again, when you're bending, I want to make sure that you're breathing. And, when you're bending, it's okay to feel pain and discomfort. You're not going to do any harm. But if you can, on a daily basis, throughout your tasks, thinking about every time you're bending to pick up your socks or you're doing the laundry, that you're actively going, let's breathe, let's move through my back normally. That would really help in your recovery. So next we go on to posture. Everyone comes into me thinking that they should have this real upright posture. And when we have back pain, I typically see that people probably try to overcorrect their posture. And if you can go back to that clenched fist analogy, if you're holding yourself upright and squeezing your shoulder blades and trying to have kind of, that nice straight posture, in essence, you're kind of going around with that clenched fist all day long. So you kind of have that increased activation of your back muscles. So what I generally like to see is that perhaps you're a bit more slumped, you're relaxed. And when we're kind of rising from sitting, so we'll go on to kind of looking at how people typically come in when they've back pain of how they stand up. Most people come into me and they're keeping their back straight. They're using your hands to come up. And this is kind of like, I kind of say, it's like a co-contraction, so people pushing down through their arms are kind of, increasing that intra-abdominal pressure within your tummy and increasing activation of your trunk muscles. And if you can see in this video, Stephen here is going right upright. He's not flexing through his back. He's pushing through his arms, trying to keep his back straight. And when we look at the function of your arms are for reaching and for pulling, not for standing. Your legs are for standing. So it's really important that when you're kind of rising from your chair, that you're using your legs. So this is an example where we get Stephen trying to keep his arms relaxed. And you can see his nose is coming over his knees. He's not using your hands. And he's kind of really sending those hips backwards when he wants to come down. So he's utilizing his legs. And this is a lot nicer on your lower back. And it's actually a lot easier to do. So next time at home, when you're rising from a chair and you have back pain, think about bringing those knees or your nose over your knees. Think about really trying to use those legs instead of pushing through your arms. So Next, what I want to look at, once we kind of have those functional movements done, I want to do an in-depth analysis of how your muscles are functioning. And it's been shown that a lot of people who have back pain, and even who've recovered from back pain, will have this kind of altered muscle activation. And what I typically see is that patients' back muscles and core muscles are actually quite strong, and it's the leg muscles that are weak. And, you know, from a retraining point of view, what I want to do is kind of like try to get those leg muscles and those bum muscles stronger. And I want to be really specific when we're exercising. So the next slide will show kind of some examples of some, you know, specific exercises. And every exercise that we give at this stage can be tailored, you know, to your needs. But what I'm looking for is that when you're exercising it, you're feeling it in that right muscle group. So when I give you kind of a bum strengthening exercise, I want to know that, yes, it's your bum that's working and not maybe, you know, the muscles in the front of your thigh or the muscles in the back of your thigh. And the first exercise here is, you can see Kieran, he's doing what we call a hip thrust. And this can be modified into a lower level by perhaps doing what we call a bridge, or it can be made slightly harder by going into a single leg hip thrust or adding on a weight. And the next one you'll see him, he's doing kind of what we call a kind of sideline hip abduction. And you'll see that this green band, this is called a TheraBand, and it's a resistance band. So, you know, he's pulling up against a bit of resistance. And this resistance is really, really important, because what we're looking for is that we're developing some changes in those muscle fibers so that you're getting kind of like those strength changes that you need in order to help with your recovery. And when we're bringing you through an exercise program, it's really important that you're kind of working at a level where those changes will happen. So I generally say an effort level of 7 out of 10 is what we're aiming for. And when we're looking at repetitions, you know, doing, you know, 8 reps or 7 out of 10 should be sufficient to kind of allow you to get the changes that we need. But it is all about being specific within that muscle group. So next we kind of go on to what we call, you know, strength training. So we're kind of looking at the whole body, you know, and there's guidelines from the World Health Organization, and they say that all adults should be doing at least 2 days of training per week. And in order to see changes kind of in your pain levels and in your function, it has to be a progressive strengthening exercise program. And this can take, you know, 3 to 4 months. So this is where, you know, what I typically see, you know, in clinic is some patients come back to me and they go, doing the exercises, I'm not seeing any changes in my pain levels. But what I'm actually seeing is I'm seeing changes in your strength. And it takes time for some of these strength changes to kind of correlate to a reduction in your pain levels. And this is where not kind of giving up on your exercise program and keeping that hope is still really, really important. And you can see to the right of my screen, I have some cross-sectional pictures of an MRI scan. And what I'm looking at here, I'm looking kind of at your the 2 kind of black circles at the back of it, and they're called your paraspinal muscles and your multifidus. And the picture to the top left-hand side kind of is normal good muscle fiber. And then as you go down through the other 3 pictures, you can see there's a lot more white within these back muscles. And that's what we call fatty muscle infiltration. And that gives us an idea that those back muscles just are not working. And that may be contributing to your pain. And a study that was done here in Spinal Sports Clinic back in 2015 found that patients who did a kind of a progressive loading free weight exercise program actually had a reduction in their pain and improved quality of life, improved function, and this correlated to kind of an increase in kind of in muscle fiber architecture on these MRI scans. So strength training does work, but you just need to give it time. You need to put in the effort and you need to be consistent. So what else kind of is evidence-based care? We need to look at cardiovascular exercise. And the research will tell us there's no right and wrong. And my recommendation for you tonight is to really pick something that you enjoy. And it's about that consistency. So again, the guidelines are recommending that we're doing between 150 to 300 minutes of moderate cardiovascular exercise per week. Now, obviously, you're going to me, I have pain, I'm not able to do that. And that's okay. I suppose my tip is to start small and to gradually build it up. And there is a kind of research to show that actually walking is such a great exercise for people who have back pain. And this was a study that was on kind of the Guardian newspaper, and it was published in the Lancet journal, and it was done in Australia. And they looked at people who had recovered from low back pain, and they put them on a walking program. And what they found were the people who engaged in a consistent walking program actually had a reduction in their flare-up and the severity of that flare-up. So kind of, simple exercise, you can go outside, it doesn't cost you anything. And again, you can just start small. You can walking around the house, if you have a severe amount of back pain, it's building it up and then gradually trying to progress it. So the next, managing a flare-up. Okay, so what do we do? Flare-ups can be very distressing. And again, they can be quite disheartening, especially if you're improving in this journey of managing your back pain. And, once you have an episode of back pain, you have an increased risk of developing another episode of back pain. The first thing I would suggest is don't panic. You haven't done anything serious, okay? And it will get better. And if you've had previous, flare-ups of back pain, you know that it will get better. And again, what we want to kind of see is that you're trying to still keep those normal kind of functional movements going. So you're still using your breath work. You're not trying to protect, your back. Trying to do some simple exercises while you're in this flare-up will actually help you recover quicker. So it's all about keeping moving, but pacing yourself. So, if you typically would have gone for half an hour walk, perhaps during a flare-up, you're going for 2 5-minute, walks, paced throughout the day. And on my next slide, we have an example of some exercises. One of my favorite exercises is what I call a child's pose. And this is, again, a really nice, safe exercise. You're kind of getting a nice stretch through those muscles along your back. And again, you're using your breath, and you can hold this stretch, for anywhere between 10 to 30 seconds. You're doing simple knee hugs, even just bringing one knee up to your chest at a time. If able, you can bring the 2 knees up. This is Kieran here doing some breathing. And I generally kind of recommend patients during a flare-up that you might go onto YouTube, find a nice, meditation video, and just focus on that belly breath, trying to relax through those back muscles. And then what do we do after a flare-up? We actually want to get back exercising, okay? And again, you may not be able to get back to the load that you were lifting prior to a flare-up, but as soon as you feel able to, you're getting back into the gym, you're getting back down onto your exercise mat. And this is kind of a picture of Stephen doing some of his strength work. So here's kind of a nice goblet squat, getting the muscles in the front of the leg going. You might be able to go into a nice split squat. And all of these exercises, again, really safe for people who have back pain. You're targeting the leg muscles. And the main thing is, after a flare-up, we're really striving for function. And I suppose that's one thing that I really try to encourage, my patients to do, is to set goals for yourself. Try not to be chasing your pain, but chase your function. So look at, in conclusion, there's no one magic solution. And I suppose everyone's journey of back pain management is quite different. Consistency is key, and it does take time. And flare-ups will happen, but what counts is really how you manage them and you get back on track, and you have that kind of end goal in sight. And if you've got any questions, I'd be really happy to answer them now.
Claire, it was a really interesting talk and the questions are flying in now, so we'll start. Can Pilates cause flare-ups in pain? A person's currently doing mat Pilates weekly, but finding flare-ups in pain since they started, and they are doing it under physio supervision.
Yeah, Fiona, that's a really, really good question. And I suppose I typically would hear that sometimes people come into me and they're doing exercise and it's causing their back pain. And it's not that the Pilates or the exercise is bad. Sometimes it's down to your technique. So, I typically say that if you're feeling it in your back, it's a sign that you're using your back muscles and not necessarily your core. So a lot of the times it's just down to your technique of how you're doing some of your Pilates exercises. And if you kind of remember my talk, I was talking about a lot of diaphragmatic breathing and using that breath control. And that is really, really important to help relax some of those back muscles. So it might be worthwhile that if you're finding in a class setting that that's flaring up your back pain, that perhaps you're kind of going for a one-to-one session and that you're kind of really trying to work on, your technique and how you're performing, the exercises so that you can get a lot more specific with how you're activating your core.
Thanks, Claire. Now that someone else is, I'm going to bring this one in because it's about yoga as well. They're saying, is there a positive relationship or benefit between lower back pain and hip opening yoga movements?
Yeah, there is. And I suppose, a lot of the times it's about if you're kind of stiff in one segment, you're going to have to gain that movement through moving another segment. So a lot of the times if we see patients in our clinic, if they're really, really stiff in their hips, they generally tend to overuse their backs. So if you can kind of free up your hips and allow them to move a lot more effectively, a lot of the times that can help improve your back pain. And some of that stiffness within the hip can be freed up not only through stretches, but also through strength training as well. So trying to get those kind of like hip muscles working a tiny bit better. So yeah, there definitely kind of is that correlation between the lower back and your hips.
Lovely, thank you. How best would you deal with very stiff lumbar vertebral discs?
Yeah, again, I suppose, what we always do is treat the person in front of us. And again, it's trying to, get that flexibility back into your spine. And there's various ways of how you may do that. And it's kind of really that bespoke exercise program, per person. So you kind of want to know, well, maybe what's driving that stiffness. Is it that there's that kind of like tension in your trunk muscles, and do you need kind of a bit more relaxation techniques? Is it that your back muscles are just not allowing you to move because they're compensating for weak hips and weak legs, and that actually your treatment program needs to be more targeted towards your leg muscles? And then you have, the classic stretching program that some people, can do kind of on a daily basis, to help with that. But a lot of the times you're kind of trying to bring it back to function. How is that stiff back affecting you day to day? And you're kind of trying to maybe drive your exercise program to your function, as opposed to just maybe trying to get a really flexible back.
Yeah. Okay, thank you. Tips for driving if you've sciatica, and also what are the best swimming strokes for neck and lower back pain?
Yeah, so good question. And, it's horrible when you suffer from sciatica. There's nothing worse than nerve pain. So I definitely feel for you. But driving, I suppose, a lot of times with sciatica, your nerve just doesn't like being stretched. And when you are driving, unfortunately, that can put extra stretch on that nerve and cause irritation on it. So best tips that I generally say is, take regular breaks, kind of avoid long journeys. So if you know that you're going to be traveling 2.5 hours, maybe every half an hour or 40 minutes, get out of the car, do a little walk around. Also, maybe try not to have your car seat, bolt upright. So change, the angle of your car seat, and you can kind of vary it back, back and forwards throughout your car journey as well. And they're probably my two main tips of how to limit irritation of that nerve when you're driving. And the second part, maybe, swimming, again, it's, I generally kind of, again, really patient, specific. If you have a lot of pain on that, like backward bending, through your lumbar spine, then, trying to maybe limit, going into your breaststroke or your backstroke can be quite good. And again, you're kind of looking at that whole spine. If your neck is really stiff, you want to avoid the amount of times that you're rotating it from side to side. So sometimes spending as much time in the water with your head in neutral can be better as well.
Okay. Do you find that there's a difference between ages and gender and how the way people progress if they're doing strength and conditioning physiotherapy?
Yeah, I think, I suppose, improvements can be kind of multifactorial, and we know kind of from the talk that, like, different factors can feed into patients' improvements, and one of them is making sure that people are doing it consistently. But regards to ages, I think once you get kind of over the age of 65 and you're getting some changes within those muscle fibers and muscle bulk called sarcopenia, sometimes it can take a bit longer to build up the strength. And that's where probably adding on resistance and weights is even more, important. So sometimes the older you get, the harder it is to build that muscle bulk. With regards to gender, again, like, that postmenopausal woman, with the hormonal changes, again, that can influence your ability to put on, muscle bulk, as well. So yeah, there can be that changes kind of in the gender as well.
Can physio improve spondylolisthesis? I've probably said that wrong.
Yes, spondylolisthesis. And again, I suppose as a physiotherapist, we're not going to, I suppose, change a specific, structural change within your spine. So what spondylolisthesis is, it's kind of a forward slip of one bone on top of the other. And this can kind of vary to, different degrees. And while it's nice to know kind of a specific diagnosis, we still treat what we see with regards to your movement and your strength deficits. So physiotherapy can, definitely help improve that, because a lot of the times the first line of treatment is non-surgical.
Yeah. And I suppose that leads into, how do you know, if you're seeing somebody and you're assessing them, how do you know which is the best route to go?
Yeah, so we kind of in Stanford Sports Medicine, we kind of use an outcome measure. It's called the Start Back screening tool. And that even helps us guide what's the best form of treatment for you. And we just use it as a guide. Like, again, everyone has their, bespoke treatment program. But some people actually just need advice on how to self-manage. And they can go and do their own exercise program. Another kind of cohort might just kind of need kind of, an exercise, program. And then you have that other cohort which need a bit more of an MDT approach, having some, psychological, approach. So, at work, we tend to use that to help guide us, but we're also really listening to you, what's your preference with regards to your exercise and, what type of exercise training do you like? And again, we really try to kind of like fit it into your schedule as well. So while it's recommended that you might be doing strength training 2 to 3 times a week, if you have a really busy life and you can only fit it in once a week, then we'll work around that, or, we'll give you, tips on how to incorporate it a tiny bit more, into your schedule. So there's various tools that we use to really create that bespoke training program just for you.
Is cycling good for lower back pain or should be avoided?
Yeah, no, I love cycling. I think cycling is one, it's like, I suppose there's no one exercise that's better than the other. But I really like cycling. I think it's really, really safe. I think the back is in a nice, relaxed, position. You're getting the legs, working hard, and you're getting a bit of cardiovascular, fitness as well. So I'm a big advocate for cycling.
Yeah. And someone's asked about swimming, as you've mentioned. They've asked about, you find swimming as well. You've already answered that one as well. Can deep tissue massage help?
Yeah, you know what, I suppose, again, when you look at kind of, any of the guidelines, manual therapy is part of kind of an evidence-based care. I suppose the issue is that you just don't rely on it. It can definitely help in acute spasm and acute episode of pain where you do manual, therapy. And I would typically say, while the majority of my treatment sessions are exercise-based, in a certain cohort, they might need 10 to 15% of that treatment session, which is manual, therapy, just to help get them moving, help reduce their pain. So yeah, it's definitely a good option, but not in isolation.
No. Is paresthesia increasing intensity into the foot, radiating into the calf, hamstring? This is about a patient, I think, who's back pain. And pain in general with movement. I think they're just asking, is it a concern if there's increasing paresthesia?
Not necessarily. I suppose when you're listening to that, you're kind of going, okay, is it a nerve irritation? If it's paresthesia alone with a small bit of pain, you know, and I suppose one of the advantages of seeing, you know, a patient kind of face to face is that you're doing a thorough examination. And I suppose, and, you know, part of that examination is, you know, ruling to see is there any kind of signs of something serious going on, like cauda equina, but also another part is your neurological examination. So if patients have those symptoms, but your neurological examination is completely normal and you're happy that it's definitely coming from the spine, then kind of that watch and wait approach, you know, is fine, where you can bring them through kind of a guided exercise program. So not necessarily option for concern, but it's something that you're monitoring, because I suppose what we do know with like spines and, you know, lumbar spine is that can be an evolving pathology. So what presents to you on a Monday may be completely different in 2 weeks' time. And that's the importance of having that baseline neurological examination.
Okay. Someone who they said they've back and neck pain for 30 years, MRIs, X-ray, they've osteoarthritis, it's age-related wear and tear. But at this stage of their life, they can't do any bending or lifting as the excruciating pain, and their neck and shoulders are painful. Any suggestions or where they go with that one?
Yeah, and it's hard because sometimes you get into like this kind of like a cycle of pain and stiffness, and more kind of stiffness can cause more pain, and we tend to stop moving because of the pain. But actually, if you can gradually build up, you know, exercise, some of that pain, you know, will reduce. And I suppose you're not going to do more damage by, you know, moving into pain and exercising, you know, into pain. And like it sounds like this person has some, you know, pain in various different areas, and it's going on for quite a long while. So potentially this patient could be good from an MDT approach as well, that it's not just kind of, you know, physio, you're looking kind of at that wider, you know, picture. But it is important that we're kind of getting some movement into the body. And a lot of times patients who are presenting with chronic pain, I tend to try to chase function as opposed to pain. So, you know, you may still have the same pain levels, but can your function, you know, improve? So I would, in that situation, chase function as opposed to pain sometimes.
Okay. Now, somebody here is asking about what's typical time to get an appointment privately. Now, with a consultant, it probably varies on what consultant it is. If it's urgent, you probably will, your GP, if he marks it urgent, or your physio does, if they're very concerned, probably consultant will get an MRI and see you then. For physio, Claire, I'm not sure at the moment, what's the appointment time?
Yeah, look, I would probably say we've no waiting, you know, list. Do you know what I mean?
Yeah.
I suppose we have a large team working kind of in UPMC and Surgery Sports Medicine. You know, so we always kind of will slot you in someplace. So we are, and like we work Monday to Friday. You know, so I would say no, we'll get you in, you know, within, you know, a week to 10 days.
Lovely, thank you. Just someone said they're a physiotherapist. Lovely talk, and the language used was very patient orientated, and I've learned some good tools for communication in my own practice, which is nice to hear. Thanks for joining us tonight, and thanks for everybody that joined in and asked questions. Please fill in the evaluations when they're sent out to you, and keep an eye on the website for any future events. And as I said, you can go back to the portal to look at past events, and this one will be on if you want to direct anybody to it. So thank you again for joining us tonight. Thank you.